Protocol-driven. Right, we're here.
Thank you very much, Professor Tom Bourne, for inviting me to give this talk. Thank you for all of you for coming and staying, and of course the online audience. It's a tough talk to give at the end of the day, 25 to 30 minutes on gestational trophoblastic disease, so please bear with me. It's the equivalent of a skank shift in Vegas when you're working at a bar from 2 a.m. till 5 a.m. So anyway. Thank you. So my name is Surgeon Sasso. I've been introduced already. Title of the talk, Diagnosis and Management of Gestational Trophoblastic Disease. What will I talk about? Introduction, first of all, a little bit about GTD, definitions, terms, epidemiology, how this pathology presents, how do we investigate it, diagnosis, how do we treat it, and then a case example. I hope we will have time for at the end of an APSN. This monstrosity of a building, postmodern brutalist architecture. I have no idea why we don't build things anymore that are for posterity, for our kids, grandkids, etc. This is very ugly. It's Charing Cross Hospital in West London on Fulham Palace Road, but it is the National Centre for Trophoblastic Disease and the National Centre for Ovarian Germ Cell Cancers, both rare conditions. I'm lucky enough to be the technician for the centre, i.e. the surgeon, surrounded by very intelligent medical oncologists. The main centre is in London. It gathers all the data. There is a centre in Scotland, in Dundee, and there is a centre in Sheffield that is there to help out. 1,800 registrations per year, and 150 of these cases will need chemotherapy. For me, gestational trophoblastic disease is I kind of love it and hate it. So love it because it's very unusual, but I hate it because it's a memento mori. So at the time of conception of life, you need trophoblastic cells, which are there to form the placenta to nourish that fetus. So it's from a philosophical angle, it's beautiful, but at the same time, they can lead to death. So memento mori is a reminder of death at the time of birth. That baby that is born is surrounded, and all of us are surrounded by this bubble of eventual death that will one day come. So there's a certain philosophy about it. Anyway, moving on. Some deep stuff on a Saturday afternoon. So gestational trophoblastic disease is a group of uncommon conditions associated with pregnancy. They originate from trophoblast cells that, as I said, one day will eventually form the placenta. Classified into two groups, benign and malignant. So you looking at the benign group, you have the partial and complete hydatiform mole. Hydatiform, I always used to wonder what the hell this word meant, and I only discovered it about 6 months ago when I Googled it. It's an amalgamation of an ancient Greek word, hydatis. Chris Kyriakou may know, I don't know if you know. He grew up in Yorkshire, so he probably won't. But teardrop, vesicular-like, and formis, which means body, so resembling a tear, which is how it looks like on pathology slides and ultrasound. Exactly. And then malignant, defined as gestational trophoblastic neoplasia, so GTN, invasive moles, and then these three cancers, choriocarcinomas, placental site trophoblastic tumors, and epithelioid trophoblastic tumors. Apologies. So I'm not a geneticist. I'll be very quick with this slide. Molar pregnancy, the complete side, you have a duplication of a single sperm following fertilization of an empty ovum. It's diploid. You have two sets of paternal genes. There are no maternal genes with regards to this, and there is no fetus on ultrasound. Very easy to divide the two. 46 chromosomes. With partial, you have two sperm that fertilize an ovum with evidence of a fetus and fetal red blood cells. So you have 69 chromosomes, and it's a triploid cell. So diploid with complete, triploid with partial. 46, 69 are the two numbers to bear in mind. From a cancer angles, GTN may develop after a molar pregnancy, a non-molar pregnancy, or a live birth. Incidence 1 in 50,000, so very rare after a live birth. And at the moment we're dealing with a patient. Listen to this. So she tragic baby born. Sorry again, with the pressing.
Is this going to go to Greek as well?
No, it's not. But 2 months, baby was born, nothing on ultrasound during pregnancy. Found to have some issues following birth. Died after 2 months. 100 and something cases around the world. Bit of retained placenta a few months after. Removed. And the pathology came back as a choriocarcinoma, which is 1 in 50,000. So the chance of this happening is 50,000 times a million, about 50 million, 1 in 50 million. Anyway, we're trying to see if this can be treated and ensure future fertility. The UK program is amazing. This is one of the success stories when it comes to cancer, 98 to 100% cure rates. And chemotherapy rates with GTN after partial moles, 0.5 to 1%, and about 15% in complete moles. The biomarker to think about here is hCG, human chorionic gonadotrophin, which is produced by trophoblastic in placenta. Fantastic. Early detection, early detection is possible for GTN. That's the beauty of it. The hCG starts to drop after treatment of moles, and then it plateaus, and it starts to pick up again after. Epidemiology, high frequencies in Southeast Asia, the Middle East, and Africa. 2 main risk factors are extremes of maternal age, so very young, and older women, and a prior molar pregnancy, which suggests an increased risk of abnormal gametogenesis and fertilization of ovum at extremes of reproductive age. All very rare, 1 in 1,000 for a complete mole, 1 in 50,000, as we said, for a chorio. Frequency increases, obviously, if you've had a previous mole, so 1 in 80 for the chance of it happening a second time, and the chance of it happening a third time is 1 in 6. So moving towards presentation, investigations, and diagnosis. The presentation is very simple. Usually tends to be women at about 8, 9, 10, 11, 12 weeks who present with bleeding, or it can be at the level 1 ultrasound scan. Those textbook complications, the kind of fascinating ones of hyperemesis gravidarum and uterine enlargement, preeclampsia, etc., we don't really see them very often. Why? Because this would be later on. You're looking at 15 weeks, 16 weeks, 17 weeks. But now we have, of course, ultrasound, which has become such a big part of obstetric care, even from the first trimester. Here's an example of, you'll guess, right, a molar pregnancy. Level 1 scan, multiparous woman in her 30s, presented at 12 weeks, and this was found. So some clues: there is no gestational sac there is no embryo there, very much resembling placental tissue with these cystic appearances, a honeycombing pattern, had a surgical management, and was found to have a complete molar pregnancy afterwards. Partial moles, much more difficult to diagnose, but 40 to 50% accuracy with ultrasound, generally speaking.
Is that a video?
No.
This was not a video. You have your embryo there. It is a miscarriage, and then above it, you can see this enlarged placenta-like villus tissue with, again, cystic spaces within it, which should raise a suspicion. The patient underwent surgical management, and a partial mole was diagnosed. So kind of in summary, break it down. So with a complete mole, you're looking at a polypoid mass, 5 to 7 weeks, with no gestational sac, no embryo. 7 to 8 weeks after, you're looking at a thickened cystic appearance of villus tissue. With a partial mole, there is usually an empty sac there, or a delayed miscarriage, with an enlarged placenta, or again with cystic changes within a decidual reaction. Sometimes you can see this kind of ratio transverse to anterior posterior dimension of the gestational sac is greater than 1.5. But those are the clues you're looking for on ultrasound. And a complete molar pregnancy usually much more easier to diagnose on ultrasound. Moving on to cancer, post-molar GTN is usually diagnosed with hCG surveillance, i.e. you treat your molar, the hCG doesn't drop to less than 5. Make sure you use the correct hCG assays. Most hospitals will now have this. And be wary of persistently low hCG levels. So it does need to drop to less than 5. 10 is not good enough, 9 is not good enough. Why? Because it can be persistently low for a while, and it starts to rise again at some point. Figure criteria for diagnosis, you're looking at plateau of hCG, which lasts for 4 measurements over a 3-week period or longer, so days 1, 7, 14, and 21. Or there is a rise in hCG 3 consecutive weeks, 1, 7, and 14, or you actually get a histological diagnosis of GTN. This is an example of GTN. So this patient underwent surgical management miscarriage for a suspected mole. The hCG went from 14,000, dropped to 3,000, but then rose again to 9,000 during follow-up. And again, you're looking at placental tissue, very vascular, with no gestational sac and cystic spaces within. After a non-molar pregnancy, can GTN occur? So 50% of the time, it occurs after a molar pregnancy, but the other 50%, it happens after a normal pregnancy. It can be an abortion, it can be ectopic pregnancy, it can be a term pregnancy. So be wary of the woman that comes and sees you in your general gynecology clinic 2, 3, 4 years later. Persistent bleeding, not going away, normal ultrasound, has tried hormonal contraception, but she's still bleeding. You know, these are young women. A lot of the time, they might have even seen other gynecologists, and a hysteroscopy would not have been offered because the scan is normal. And a lot of these women, as we found in our retrospective studies, the ultrasounds are normal. The MRI is normal. Do offer a hysteroscopy and get a biopsy. Management. With a molar pregnancy, again, simple. Surgical management is key here. And there are preoperative, intraoperative, and postoperative considerations. Preoperatively, you want to prepare the cervix because you do not want to perforate that uterus. So do think of giving a prostaglandin. Afterwards, do not use oxytocin infusions if there is heavy bleeding until evacuation is complete. And do avoid ergometrin and misoprostol because you can get embolization of the trophoblastic tissue. If there is heavy bleeding, do not wait. Get on with your surgical management. Warn the patient that you may need to use hemorrhage interventions. So, for example, Bakri balloon, Foley catheter, circulage, and do consent them for a hysterectomy. Rare that this will happen, but you may have to do it. And make sure, if it's an ultrasound course, make sure that you're doing this under ultrasound guidance to ensure that most of that cavity has been emptied. They are likely to require transfusion, so they need to be cross-matched prior to surgery, and give anti-D if rhesus negative. Follow-up, it's pretty simple. They will have hCG monitoring. They don't need a scan. So hCG once a week, you're looking at normalization within 56 days, so 8 weeks. And if that has happened, then you will follow up for 6 months following uterine removal. If the hCG hasn't reverted, then you'll start from the moment that it does normalize, and then you will look at 6 months. So that's for complete molar pregnancies. There is no effect on future fertility. So please, a lot of reassurance for these women. This is a long follow-up, 6 months. Reassure them there is no effect on fertility after. They need to focus on good contraception for those 6 months, and then afterwards they can try wait for a period or 2, and they can try again. So a lot of reassurance for the patient. With partial moles, they don't need to wait 6 months. You need normalization on 2 samples that are 4 weeks apart. If there is no chemotherapy, you do not need to repeat or check that hCG following the next pregnancy event. With cancer, so neoplasia, we'll cover this quickly because a lot of you won't have to deal with this. The patient will be referred to a center, but patients will require chemotherapy, so single agent or multiple agent. The regimen depends on stage and classification. How do you classify? Depends on a risk score, which I will show you. With regards to GTN, all of these patients need to be staged. So if you're seeing them in your local unit or a hospital that's far away from the center, it might take a couple of weeks to get to the center. Although Charing Cross is pretty good. If you email them, they respond relatively quickly. Definitely you would have done an hCG. Do offer a Doppler ultrasound and do a chest X-ray. Chest X-ray is imperative for staging. If that chest X-ray is normal, they don't need any further imaging, and just wait for them to go to the center. If the chest X-ray is abnormal, so potential metastases, They need to get to the center as quickly as possible. Again, if there is a delay, do a CT chest. And further, if the CT chest is abnormal, you can offer MRI. So MRI brain, MRI abdomen, MRI pelvis. So full staging of the whole body. With gynecology, we rarely do MRI brain. This is a disease where we sometimes have to. Figo staging, very simple. Stage 3 or 4 is if there is disease outside the pelvis. So if there is disease in the lungs, it's stage 3. If there is disease in the rest of the abdomen, brain, and so on, it's stage 4. And in terms of Figo criteria, you may remember this from your exams, part 1, part 2. Still, remembering all 8 is not easy, but age, antecedent pregnancy, interval months from end of index pregnancy to treatment. This is key when you decide what kind of chemotherapy. Pre-treatment serum hCG, large tumor size, size of metastases, number of metastases, and previous failed chemotherapy. Don't ask me how they came up with this and why they decided that these 8 were important. I don't think it was like the ADNEX model, which was based on over 30,000 masses and multiple studies. I've no idea, but these are the 8 that are still used. So there's a study. This was a lady who had a miscarriage, retained products, again, removed. Whilst waiting for the pathology, the hCG never really dropped. It rose up to 445,000. You're looking at huge, huge numbers. And it came back as a choriocarcinoma. The patient had lung and brain mets. It all sounds pretty scary, but actually even for stage 3 to 4, you're looking at about 95% treatment. So the outcomes are very good, and as I said, very much a success story when it comes to oncology. With low risk gestational trophoblastic neoplasia, so going back a step, that Figo staging criteria, those 8 markers, if the total is 6 or below, it's deemed to be low risk. If it's 12 to 7, it's deemed to be high risk. If it's 13 or above in terms of score, it's ultra high risk. For low risk, you can offer hysterectomy if the family is complete, or chemotherapy in the form of most commonly methotrexate with folic acid. That doesn't work. You can offer actinomycin D, and then there are other chemotherapy regimens. You would offer consolidation courses a couple of weeks after. You would then monitor for up to a year. At that point, if the hCG is still normal, the patient can go off and get pregnant. Very rarely do patients actually wait. As soon as it's gone down to normal, they don't wait for a year, they try again. How long are they followed up, whether it's low risk or high risk? For 10 years at least, they will have serial hCG. So monthly up to 12 months, and then yearly up to 10 years. With high risk, you go into multiple agent chemotherapy. You do not offer hysterectomy for these patients. The disease has spread. And again, you have different types of chemotherapies. And actually what's unusual about is the different number of chemotherapy drugs. So Emaco is number 1 regimen. You can see the etoposide, methotrexate, actinomycin D, cyclophosphamide, and vincristine. So 5 different drugs. But overall survival rates at 95%, even if it's high risk GTM. With ultra high risk, again, you can see salvage therapies, so you keep going down all of this to arrive at something that works. These are the tricky ones, so a lot of these women will struggle, extremely rare. Some success now with immunotherapy with pembrolizumab. The big danger here is if you offer them high dose and multiple agent chemotherapies, they start bleeding. They can bleed internally, they can inside the brain, inside the lungs, etc. Surgery, which is obviously why I'm a Charing Cross. We said hysterectomy. So hysterectomy is offered for low risk GTN, and it's offered for 2 types of cancers, your PSTTs and your ETTs. These are very chemo resistant, so you want to try to catch them stage 1. We get phone calls from patient might be in Scotland. We had a patient who was on one of the islands, the Outer Hebrides, who was diagnosed with this and had to be flown into Glasgow, and then from Glasgow to get a train to be operated as soon as this diagnosis was found, because you want to catch this at stage 1. Once it's spread, it's chemo resistant, you're looking at a 50% survival rate. In terms of the type of operation, keyhole is usually fine. A removal of uterus with tubes to ensure a good margin in case the disease is found towards the cornua, And of course, as a gynecologist, you always think of ovarian cancer in the future. Why else would you offer surgery? So laparotomy to stop bleedings from other organs, neurosurgery, and then resection. So sometimes I have to operate on patients that are chemo-resistant with multiple spots of disease around the abdomen. So the only option here is to try to remove that surgically. Fertility preservation is possible. It's usually for your low risks and the high risk GTNs. So if a patient is declining chemotherapy, or the chemotherapy hasn't working, you can offer fertility sparing. So PSTT, this is tricky. So PSTT is chemo-resistant. Treatment is a hysterectomy. Then imagine the scenario of a woman who's never had a baby, like the one that we're dealing with at the moment. We did this a couple of publications in BJOG. So a modified Strassman procedure is a type of procedure where you remove a section of the uterus, all three layers, endometrium, myometrium, serosa, sew it up together. We've had one pregnancy following this in a woman who was diagnosed with a PSTT. So it's all quite experimental. And finally, just to finish off with a case, so this was a 42-year-old woman who had bleeding. She had 2 previous children, a 3-year-old and a 7-year-old, a miscarriage a year ago before we saw her. She had a normal hCG. She was seen in her unit, felt to have a polyp, which was removed and found to be a typical placental side nodule, APSN. This is precancerous. 10 to 15% of these patients will one day progress to a PSTT or an ATT. What do we do? What was done for this patient? She was correctly referred to our center. She had full imaging, so MRI pelvis and MRI brain, and CT abdomen and chest. Nothing found in terms of potential metastases. Genetics was done as well for this patient, and an APSN seems to have been derived from the 7-year-old child. So in terms of are we concerned here or not, remember the four-year cutoff for these pathologies. So anything that's within 4-year remit, if this turns out to be cancer, they do much better. After 4 years, they could potentially be in trouble. So in terms of what to do for this patient, any ideas? APSN, precancerous?
Well, you're an oncologist, I would imagine probably take out everything from people's liver and twist them out.
Well, likely not everything, but yes, it's precancerous. She's had 2 children, so you'd probably be hinting, let's offer a keyhole removal of uterus and fallopian tubes. And this is indeed what she had.
With a wide margin of normal.
But look at the pathology. So she had an epithelioid trophoblastic tumor, stage 1, fortunately, with no LVSI, lymph vascular space invasion. So for this patient, because it's stage 1 and there is no LVSI, we breathe a sigh of relief. But as it's after 4 years, you would offer her some chemotherapy, and then you would monitor for some time. And then follow up, remember, for any of these tumors, it's kind of indefinite. So we say 10 years, but actually they follow them up for even longer because the evidence is rare. We don't have enough evidence. So we keep going for more than 10 years. That's it. You'd be happy to hear. I always finish with this slide just to thank all the people with whom I work on different areas who made me the man I am and still make me the man I am. Thank you.
They've got lots to be responsible for, clearly, surgeon. So, any questions, or has that exhausted everyone with oncological stuff? I mean, I don't know what everyone else thinks. I mean, clinically, rolling us back.
Yes.
Partial moles, and then versus hydropic changes in miscarriages, I think in a sort of classic early pregnancy environment is problematic because you see people with these cystic changes, and I don't think it's always very clear what it is. And are there any features that might be helpful to help people, or is that something do other people agree with that, or in clinical practice? Because I think if you look at, you generally often will get a partial mole diagnosis back from histology, which is unexpected, or we think it's a partial mole, and then find out it actually wasn't, it was just hydropic. But it seems to me it's quite hard to answer that. But I mean, do you have any insights on that, or is there any other offers from the audience? I don't know if Dirk has a view or anyone. But I think that can be quite difficult.
Management is the same, pretty much, isn't it? And the key is retain the tissue.
Yes.
You're likely to push them towards the surgical management.
Yeah, exactly.
So
No, it doesn't change management in a sense, but I think it does alter your management in terms of pushing people towards a surgical solution and having clear histology.
And sometimes there are delays if you have to PUV them because it's not that clear. So then
the PUV.
1 to maybe 3 weeks before you diagnose a miscarriage, and then they have surgical treatment.
I think it's a potentially radiomic study because you at the end of the day, you're looking at, forget about the fetus, you're looking at the placental tissue.
Well, that's actually exactly the point. The other thing is that a lot of people have follow-up pregnancy tests and so forth to pick up moles following, conservatively managed miscarriage. Do you think that's the prevalence of the pathology is high enough to merit that, or do you support that as a practice? Doing pregnancy tests following miscarriage just in case there's a mole and so on. Some people
I
do
think
that.
it's
It's not surgery, so whatever. I mean,
no, it's not whatever. I think it doesn't. I don't think from a health economics angle, I don't think it merits.
Doesn't make sense.
It doesn't make sense. When NHS, would you?
Because people do it.
Tell
Go on.
But we're doing it mainly because you're not following them up with an ultrasound scan. They've been expectantly managed, and it's reassurance at that point.
There is that, but yeah, I know, but
Rather
still
than-
people do it.
Yes.
But, yeah.
Yeah.
Okay. Any other queries? There's one question about. You're allowed one more question.
Just a quick one. More about the prostaglandin,
Yes.
misoprostol. I felt like it was conflicting. Should we give? Because we don't give it pre-op.
You should give it. Well, it is so. The European guidelines are hesitant. The Green Top guidelines say it's fine to give it to prepare the cervix, but not to give it after, to help with excess bleeding. So preoperatively, you can give it to prepare the cervix, but then be very careful afterwards. So, so if the patient is bleeding quite heavily, go more for surgical management.
Surgeon, we can have a finish there. Thank you very much.